Hi, everybody. Thanks for joining. I think we'll give it one more minute for folks to hop on. We'll start at 12:10. Okay, in the interest of time, I think we'll go ahead and get started. I think we might go right up until the end, so we'll take all the time we can get. So welcome, everyone. Thanks for joining. This is the first Minnesota Cancer Alliance webinar of 2025. My name is Haley Storms-Crupton, and I'm the Comprehensive Cancer Control Program Coordinator at the Minnesota Department of Health. So today we'll be hearing from Dr. Silvia Balbo and Kathleen Dubberley on the impact alcohol consumption can have on cancer risk. Before we get started, we'd appreciate it if you would put your name and organization in the chat. That just helps us understand who's in attendance today. And then we're also hoping to have time at the end for question and answer. So if you put your questions in the chat throughout the presentation, we can address them all together at the end. Next slide, please. Okay, so for those of you who are unaware, the Minnesota Cancer Alliance is a coalition of over 100 organizations and individuals dedicated to reducing the burden of cancer in Minnesota. The Minnesota Cancer Alliance is responsible for creating and implementing Cancer Plan Minnesota, which we're currently in the process of updating. If you're interested in learning more about the Alliance or joining, you can scan the QR code here. Give that a second. Okay, next slide, please. Okay, so with the help of the 2025 MCA leadership team, we've decided to restart the MCA webinar program. So here's a look at the 2025 MCA leadership team and the MDH Comprehensive Cancer Control Program staff. Next slide, please. Okay, now for the good stuff. So first we'll hear from Dr. Silvia Balbo. Dr. Silvia Balbo is a professor in the Division of Environmental Health Sciences of the School of Public Health and co-leader of the Carcinogenesis and Chemo Prevention Program of the Masonic Cancer Center at the University of Minnesota. Her extensive laboratory experience in organic synthesis and genetic toxicology complemented well with the training in molecular epidemiology she received during her postdoctoral work. With this background, she moved to the Masonic Cancer Center with the ability to understand and propose an interdisciplinary approach to the challenging and complex questions concerning the investigation of chemical carcinogenesis. Her focus became to develop methods using mass spectrometry to investigate the role of alcohol in head and neck cancers. And second, we'll hear from Kathleen Dubberley. Kathleen Dubberley is the alcohol epidemiologist within the Substance Misuse Prevention Section of the Minnesota Department of Health. Kathleen develops and informs programs and policies to mitigate alcohol-related harms, such as injury, chronic disease, and mortality. Kathleen comes from the Health Security and Regional Operations branch from the Public Health Agency of Canada as an analyst. Next slide, please. And then one last thing really briefly before we begin. Our objectives for today are to describe how alcohol consumption can increase the risk for certain types of cancer, share data about Minnesotans impacted by or at risk of health-related cancers, and discuss alcohol prevention strategies that can reduce cancer risk. Next slide, please. Perfect, and I'll pass it to Silvia.
Right. Thank you, Haley. Hello, everyone. It's really a pleasure to be here today and to be able to talk about a little bit of my research, but more in general, talk about the connections between alcohol and cancer, which has been really a focus of the work that I've been doing for some time now. So if we can move to the next slide, we'll just jump right on into it. Alcohol is a human carcinogen. It is classified as a Group 1 human carcinogen by the International Agency for Research on Cancer. And this is an agency that is part of WHO and that really focuses on research on cancer specifically and on the definition of how environmental exposures are posing a threat to health and defining really the hazards that come from different exposures and their connections with different types of cancers. And so it has a classification that is constantly ongoing and evaluating how environmental factors may pose risk to people exposed, and in particular, risk of developing cancer. So alcohol is a risk factor for cancers of the upper aerodigestive tract, liver, colon, and breast. And it's considered to be responsible for around 5–10% of all cancers in the Western countries. And the risk does not seem so far to change depending on the beverage. So there has been a lot of work done looking at whether this cancer risk is really changing depending on whether we consume beer or spirits or red wine or white wine. But it really seems like the risk does not change, and it is really related to the ethanol present in the alcoholic beverages that have been considered. So next slide is going to show the fact that the connection between alcohol consumption and cancer risk has been established by IARC already back in 1988. So we've known about this connection for a long time. The epidemiology has been really clear in showing that there is a connection, especially for people that are drinking heavily, with cancers of the liver, the mouth, the throat, the voice box, and the esophagus. And this was, again, very evident and established already back in 1988. In the next slide, we had an update. So IARC is producing these guidelines and reevaluating the exposures and the risks that are associated with these exposures periodically. And so more evidence has been collected and has been evaluated. And in 2012, a reclassification happened where the association between alcohol consumption and increased cancer risk was confirmed, but there were a couple of other sites that were included in the list of cancers that may be affected or that whose risk would increase when drinking alcohol, and those were colon cancer and breast cancer. So in the next slide. So finally, the connection between alcohol and cancer is now established for 7 types of cancer. I've listed the ones earlier on the upper aerodigestive tract, breast, liver, and colorectal. And so the connection is pretty clear. However, despite this clear connection, we are still trying to figure out exactly how alcohol is leading to cancer and what exactly are the steps and the processes that are triggered by alcohol consumption. In the next slide. So the mechanisms are really not clear. The classification that has been done by IARC was mostly related to the epidemiology. But even though we have clear studies that are showing that there is a connection, really the mechanisms through which alcohol is leading to cancer are still under consideration, under study, and we're still trying to figure out exactly what's happening. And the problem is that because we are also considering different sites for which alcohol is a risk, there might be also different mechanisms depending on the target tissues that we're thinking about or the type of cancer that ultimately we are considering. And so we have the hypothesis that we have potentially different mechanisms that play a role depending on the cancer that we're looking at. In the next slide. These are the mechanisms, the main mechanisms that have been studied over the past several decades, and really trying to pin down the potential pathways that are triggered by alcohol consumption and then may lead to risks that are associated to specific cancer. The first mechanism, and the next slide, is the mechanism that is related to ethanol metabolism. And so ethanol itself is not mutagenic in animal models or genotoxic in cell models. And However, when it's metabolized to acetaldehyde, this molecule is instead very reactive and it's genotoxic and can lead to DNA damage, which ultimately can, if not repair, lead to mutations and cancer formation. And this seemed to be a mechanism that is particularly relevant for the upper aerodigestive tract, so the oral cavity and the esophagus. Next. We have a mechanism instead that is related more to the induction of oxidative stress. So when drinking alcohol, we have oxidative stress that is generated. We have enzymes that are activated or induced that are producing more reactive oxygen species. And these, again, are leading to stress of cellular mechanisms. We are damaging DNA, proteins, and cells are increasing the status of inflammation. And so in that case, this seems to be a specific mechanism that may play a role, particularly in liver cancer, but also in other of the cancers that we have considered, so including breast cancer and colon cancer. The next slide shows another mechanism that really has become more clear as we have looked more into the connection between alcohol consumption and breast cancer. And this is more related to the interaction of alcohol with levels of multiple hormones, variations in the balances of hormones, including estrogen, which ultimately can really have an impact on breast cancer risk. And finally, the next slide, we have the evaluation of also mechanisms that are related to how alcohol can be leading to a greater absorption of carcinogens, acting as a solvent, and so increasing the solubility of some other carcinogens that we are exposed to, or increasing the absorption by leading to a more permeable barrier in particular in the oral cavity or in the gut. And so in this case in particular, the evidence that is related to this mechanism is related to the fact that people who are drinking and consuming alcohol and smoking are at much higher risk of developing, for instance, head and neck cancer. And this is again related or hypothesized to be related to the fact that all the carcinogens that are present in tobacco get to be absorbed more when we have the presence also of alcohol in the tissues. And instead, the increased absorption of some of these carcinogens seems to be playing a role, again, when looking at the permeability that is increased in the lining tissues of the colon. So in the next slide, most of the attention so far has been really focused on the first mechanism, and that is also part of the work that I am focusing on with my lab. And so we have been looking at how really alcohol breaks down into acetaldehyde, and acetaldehyde then can potentially lead to DNA damage and ultimately causing mutations and cancer. So in the next slide, the reason why we're looking at acetaldehyde starts from really looking more carefully at how this is formed and generated in the body. So ethanol is metabolized to acetaldehyde by an enzyme that is called alcohol dehydrogenase. And then acetaldehyde is then detoxified or then eliminated through its conversion into acetate by an enzyme that is called aldehyde dehydrogenase. And then once acetate is formed, then it's eliminated through circulation. Next slide. We know, though, that there are some individuals who have a genetic background which encodes for a variation of the efficiency of this particular enzyme, the LDH, that is represented in this scheme. So they have a genetic background that leads to an enzyme that is not that efficient in that conversion. And so they only have 10% residual activity of this enzyme. And people who are carrying this genetic background are indeed have an increased risk for cancers of the head and neck, so the oral cavity, the throat, and the esophagus when they drink alcohol. So in the next slide, This is particularly important because carriers of these type of inefficient enzymes are in high percent, around 30% in people that are of Eastern Asian descent. And so people that are coming originally from areas in Japan, in China, Taiwan, they carry 30% of the population there carries this genetic background, which leads for them to experience flushing when drinking alcohol. This means that when they're drinking alcohol, they're more susceptible to effects such as nausea, such as warming of the facial area, redness, and so they have this phenomenon. And when they keep on drinking, these people are at higher risk for head and neck cancer. So really pointing at the fact that this enzyme and that detoxification of acetaldehyde is really playing a role in that particular process. Next slide. So this fits well into the concept that ethanol gets activated, or let's say metabolized into acetaldehyde. Acetaldehyde leads to DNA damage and then genetic change and mutation. And so in my lab, we wanted to really try to figure out if this type of mechanism happens, and if we can measure the way that this DNA damage occurs in the oral cavity. So in the next slide, this is a study that we have conducted here at the Masonic Cancer Center, where we had healthy volunteers coming to our clinic, and we measured the oral cavity or oral cells that were collected with a cyto brush. We measured the variations in DNA damage after a specific amount of alcohol that we provided the study participants with. And so we looked at how the levels of DNA damage before at baseline, and then at several time points after an alcohol dose that was administered in the clinic. In the next slide, we looked at a specific DNA modification that comes exactly from the reaction of acetaldehyde with DNA, and this is called N2-ethyl-DG, which is represented here in the graph. And we could see that right after a first dose, which is corresponding to more or less one drink, we had an increase in the levels of this DNA modification in 4 hours, which peaked at 4 hours, and then reached back baseline. And this increase in the levels of this marker increased with the dose. So dose 2 were 2 drinks and dose 3 were 3 drinks. And so with this particular experiment, we were really able to identify the fact that indeed, when we do have an exposure to alcoholic beverages, we do have a direct effect on the oral cells and the DNA of the oral cavity that are affected. Again, pointing at the fact that this mechanism through the reaction of acetaldehyde and DNA is indeed something that is happening in the oral cavity, and therefore strengthening the association between this mechanism and these particular cancers. So in the next slide. Yet, despite the fact that we do have some hypotheses and ideas on what these mechanisms are, and we do even have some markers that are helping us understand exactly what happens when we drink, we're still far from being able to precisely identify the various steps that are happening and why they are happening and how they're happening in particular individuals. And so we're really far away from being able to identify more precisely people at risk. Ultimately, the question is, can we understand exactly what happens so that we can understand why it is that not all people that are exposed ultimately are developing cancer, and not all the people that are developing cancer that is coming from alcohol consumption are developing the same type of cancer. So we're still really trying to understand exactly the granularity of the mechanism so that ultimately we will be able to understand more carefully and more clearly who is at higher risk. In the next slide. Because we don't have a clear picture and a detailed picture of these mechanisms, our recommendations on consumption of alcohol are still quite generic. And so if we look at the US dietary guidelines, or that are basically summarizing what is recommended in terms of alcohol consumption, The indication is that we should have 1 drink or less a day for women and 2 drinks or less a day for men. But again, it's very generic and it doesn't take into account any kind of other types of risk factors or any kind of specific identifications. For instance, it doesn't even list the fact that or mention the fact that some people who are that are carrying that genetic background that encodes for that inactive that less active enzyme may be at higher risk and therefore may be following a different guideline. Next slide. So I think that also because, again, the mechanisms are not that clear and we're not as clear in giving guidelines, the awareness, despite the fact that, as I mentioned at the very beginning, we have been knowing about this connection for a long time, awareness still remains low. And so at the beginning of this year, the Surgeon General produced these alcohol and cancer risk advisory that really try to increase the awareness for the American people, which from a survey that really was at the base of this effort revealed that less than 50% of Americans knew about alcohol being a risk factor for cancer. And so we need to do a better job at increasing awareness and really trying to better provide information that better characterizes the risk and the factors that come into play. Next slide. So the key messages basically of this brief overview of the connection between alcohol and cancer risk are that obviously we do know, and we have been knowing it for a long time, that alcohol is a risk factor for several cancers. Next. However, alcohol is a complex risk factor. As we have seen, there are multiple different cancer sites that are linked to alcohol consumption, and there are multiple mechanisms of action that could come into play. And obviously, they're not isolated one from the other, but they could also come into play at the same time. So clearly, it's a difficult challenge to understand these various mechanisms and also the interactions that they have with other risk factors that are coming into the picture. Next. Managing this complexity is clearly not easy, and therefore also providing recommendations and guidelines is extremely hard. And again, the lack of precision and detail in some of the guidelines that we can provide really does not help us. But in the next slide, or in the next step, we can start by increasing awareness that can help us make better decisions, especially for those people or those populations that are characterized by additional risk factors. And so increasing the awareness of some of these connections, increasing the awareness of some of the mechanisms, some of the complexities, I think can really start to help us make our decisions with more information and increased awareness, and just decide what is best for us, considering the situation that is typical for each individual and all the risk factors that may be typical of one particular individual. Next. And so with that, I just want to now let the floor to the next speaker, and I'm looking forward to your questions. And again, this was just a general overview on what we know about the connection between alcohol and cancer and its mechanisms. Thank you.
Thank you, Silvia. Can someone give recognition they can hear me? Perfect, thank you. So today I'm going to cover a number of topics, beginning with an overview of alcohol consumption in Minnesota that provides a snapshot of who is drinking alcohol and the patterns of consumption as they relate to, where possible, cancer risk factors. And I'll also provide an orientation to the Minnesota Cancer Registry System, and this will be followed very briefly by how the Minnesota Department of Health has been addressing alcohol-related cancer. So let's start with discussing alcohol consumption in our state. And today I'll be using the Behavioral Risk Factor Surveillance System, otherwise referred to as BRFIS, which, for those of you who aren't aware, that's the gold standard for population health surveillance. But let's first begin with defining what a drink actually is. And excuse me. So in the United States, a standard drink has 0.6 ounces of pure alcohol, and the amount of pure alcohol in each drink depends on the alcohol content or percent of alcohol by volume. This standardized volume metric is conventional in alcohol epidemiology, and it's critical when applying it in practice, such as looking at risk behaviors and in turn implications on our population like we're discussing today. I did want to point out, however, that BERFIS has a different definition, however, which can be summed up as a serving like one can or bottle of beer or one glass of wine. And I just wanted to make that clear because I'm also going to be talking about any alcohol consumption in a number of slides, and this does not mean just sips or any amount of exposure. So that can be a little bit misleading. So next slide, how many people can actually consume alcohol, or how many people actually consume alcohol in Minnesota? So a conventional measurement in alcohol epi is any alcohol consumed, again, that one standard drink during the past 30 days. Well, in Minnesota, we have a relatively high prevalence of consumption, at least in 2023. With a little over 1/2, that is 58%. Our bordering states have a similar prevalence, and the national prevalence is a little lower at 53%. Next slide, please. And let's look at some breakdowns of who reported drinking any alcohol. And by the way, my analysis going forward is restricted to people who reported yes to any alcohol consumption. So among these adults in 2022, this is the most recent data I could get by breaking it down by sex. Nearly 2/3 of males and just over half of females reported consumption. And these sex differences are statistically significant, where more specifically, females had 23% lower odds of reporting alcohol use in the past 30 days compared to males. And this highlights that sex-based differences in alcohol use remains measurable and meaningful and should be considered in alcohol prevention efforts and policy development. And as we'll discuss, that same level of alcohol use can carry different health risks for males and females, particularly when it comes to cancer. Next slide, please. This slide shows any alcohol consumption in the past 30 days. Again, I'm keeping sex separated because of those differences by race, ethnicity. So for both groups, what you can see here is that white non-Hispanic adults showed the highest drinking prevalence, where about 2/3 of white males and white females reported any past 30-day use. On the other hand, here we see Hispanic and multiracial females had notably lower drinking prevalence at under 4% in both groups. Next slide, please. Here we have any alcohol use grouped by age and separated by sex. Looking first at males on the left there, we see a clear peak in that 25 to 44 age group, where just over 2/3 report drinking in the past month. Use declines somewhat at around 65 and older, dropping to about 59%, and is lowest among young males at around ages 18 to 24 at just less than 50%. And for females, we see the pattern is similar in shape, where alcohol use peaks among 25 to 44 and declines at around 65 and at just less than 50%. So overall, these patterns highlight how alcohol use varies with age within each sex. While young adult alcohol use is relatively lower, I do want to speak briefly to drinking behaviors during young adulthood, however. Next slide, please. And I do want to begin with encouraging news that some of you may or may not be aware of, which is that youth alcohol consumption is remarkably down compared to younger generations. But while early initiation appears to be declining, any alcohol consumption really does matter for both sexes, particularly because alcohol misuse has been formally recognized by the American Academy of Pediatrics as a pediatric health issue. In fact, the AAP identifies alcohol use disorder and underage drinking as a serious concern and further classifies alcohol use as a chronic relapsing pediatric onset disease for some individuals. Drinking patterns in young adulthood aren't always just short-term behaviors, therefore. They can be early signals of long-term risk. When high frequency or binge drinking becomes chronic, those consequences extend well into adulthood. So in other words, what starts as a youth behavior often ends as an adult health burden. And as we'll discuss in more detail, while males are more likely to binge, it's also worth noting that females, as Silvia touched on, are more biologically susceptible to alcohol-related harms, even at lower levels of consumption, including higher relative risk for those alcohol-attributable cancers. And so that's why alcohol prevention and harm reduction efforts really must span the entire lifespan, starting upstream with delaying initiation and continuing downstream with strategies to curb high-risk drinking in adulthood and take sex and gender-based lenses. In fact, here is a sneak peek into that Minnesota Cancer Dashboard that I'm going to be showing you later, which offers an example of how alcohol use between the sexes translates into real health impacts. So using Burfus, I found that weekly alcohol consumption increases odds of a past cancer diagnosis when adjusting for sex, such that males had significantly lower odds of reporting a past cancer diagnosis than females. In fact, we can see an example of how this finding may translate in that dashboard. So on the top right, we see the female burden of alcohol-associated cancers, where the overall rate is 207 per 100,000 alcohol-associated cancers, which is more than double the rate among males. And the leading driver of this difference is female breast cancer, which alone accounts for 151 per 100,000 cancers. So although my Burfus analysis didn't necessarily show a link between self-reported alcohol consumption and past cancer diagnosis, which is likely due to a bunch of limitations I won't get into right now, it doesn't just underscore a critical point, which is that females do have that significantly higher odds of reporting a cancer history compared to males. And that finding aligns with what we're seeing more broadly in the Minnesota cancer surveillance data in the dashboard. So let's take a step back from these kinds of outputs and look how population level patterns reflect this risk, particularly when it comes to breast cancer, which remains, again, that leading alcohol-associated cancer in women. And this slide shows how many Minnesota adult females may be at elevated risk for breast cancer based on their alcohol intake. So as Silvia mentioned, not only do a lot of Americans not know about the link between alcohol and cancer, but not a lot of females know about the risk of alcohol and breast cancer. In fact, drinking less than one standard drink per week over a lifetime increases breast cancer risk among females by 11%. One standard drink per day raises that risk to 13%, and two standard drinks per day raises that risk to 15%. So when I looked at the weighted population estimates, so again, the Burfus survey sample from Minnesota adults, we used to estimate how many females across the state fall into each risk group. Over 500,000 females in Minnesota report drinking more than 0 but less than 1 drink per day on average, putting them in that 11% increased risk category. Nearly 250,000 females drink about 1 drink per day, which is linked to a 13% higher risk. And then we have about 174,000 females drinking 2 or more drinks per day, putting them in that highest risk tier with a 15% increased risk. So even light to moderate drinking affects a large number of females when we look at the whole state. And if we tally all that up, we have nearly we have a very, very large number, of females. And it's a risk that not many females are aware of. So I've covered a lot already, and I'm running short on time. So I'm actually going to slide through, a large number of slides. So I did want to touch on excessive alcohol consumption. I won't bother defining everything specifically, but binge drinking in Minnesota, we run at about 18.4%, and females have lower odds of binge drinking compared to males. And among males, binge drinking is more common among the 25 to 64 age groups, with older adults binge drinking far less for between both sexes. And among race and ethnicity, next slide, please. I couldn't find a statistical significant difference between the sexes when it came to binge drinking with respect to race and ethnicity. Oh wait, I need to put that otherwise, excuse me. For females, there was no difference among race and ethnicity, but for males there were, where we see among white only non-Hispanic, 19.7% of them came in at with the highest prevalence. And in terms of heavy drinking, so that's that really chronic, sustained pattern of drinking alcohol. Next slide, please. We come in at 6.1%, which that's the standardized prevalence, but it is comparable to the crude national rate. But again, when we're considering these chronic health issues like cancer, next slide, please, that pattern of sustained drinking is very problematic. And when it comes to ages, to age groups, excuse me, what we see is that the highest prevalence of heavy drinking is among those adults ages 25 to 44. And I didn't find any sex differences when it came to heavy drinking, which I thought was quite interesting. And I did want to humanize this data a little bit because these prevalences are quite low, coming in at under 5% here when looking at it by age. So I offered the weighted estimate counts so that you can see that over 300,000 Minnesotans are drinking heavily here in our state. Next slide, please. With race and ethnicity, we have a similar trend again that we've seen with the other alcohol consumption patterns. Next slide. But here I will, with my short amount of time, point out something important, which is that despite some groups reporting lower drinking, being any drinking, binge drinking, and heavy drinking, they still experience higher rates of alcohol-related cancers. So, for example, and this is from the dashboard, American Indian and Alaska Native Minnesotans have the highest rate of alcohol-related cancers by far, 186.2 per 100,000 alcohol-associated cancers, even though their rates are not the highest, and in fact are amongst some of the lowest. Meanwhile, white Minnesotans who show both higher any binge drinking and among males heavy drinking show comparable alcohol-associated cancer rates to other groups. So these discrepancies really reinforce the importance of taking a health equity lens. And so I was given permission to go to 1250, so I'm going to take advantage of that. Next slide, please. And so really quickly, I will showcase the cancer dashboard to explore cancers grouped by associated risk factors. And this dashboard does an excellent job of taking a health equity lens. Next slide, please. You'll have access to this so you can read my slide notes to get more details that I'm skipping over, but I will mention that there's 2018 to 2022 data. Next slide. And you'll be able to access a number of alcohol-associated rates. But the most important thing that I'll mention when it comes to interpreting these rates is that these are not necessarily those fully alcohol attributable or related alcohol attributable rates that we know for certain. Put otherwise is that what we're saying is that I'll use a working example. All colon and rectum cancers we know that this type of cancer is related to alcohol. So for example, if you're looking at liver cancer, this is going to be the rate of liver cancers that we know are associated with alcohol, for example. And I hope that makes some sense. Next slide. Once you get to the dashboard, you'll have a number of different filters that you can choose from. And as you move along in the dashboard, everything will change other than the very top table. And you'll be able to access, next slide, county, race and ethnicity, which you already saw, age group, next slide, next slide, and next slide. And I'm going to stop here because what I'll do is, if anybody is interested in knowing what we're doing here at MDH with respect to advancing and informing alcohol and cancer-related decisions with respect to programming and policy, I can speak to that. And I'm also happy to answer any questions you might have directly by email, or you can meet up with me. Thank you.
That's great. Thanks so much, Sylvia and Kathleen. I think we were scheduled to end at 12:55, so we have about 5 minutes left for questions. And if you all want to hang out with us afterward, that's okay too. So if you do have questions, you can go ahead and either raise your hand and unmute yourself, or you can just put your question in the chat and we'll read them aloud for Sylvia or Kathleen. And I did want to mention, Kathleen spent a little bit of time talking about the Minnesota Cancer Reporting System Cancer Risk Factor Dashboard. It's a bit of a mouthful, but Michelle put that link in the chat for folks if you want to investigate it a little bit. And it's also linked in Kathleen's presentation, so it can be accessed there too.
Hi, I don't know if anybody can hear me. I wasn't able to type in the chat, but I'm Shar, RN from Indian Health Board, Minneapolis. I was just wondering, why is it that it looks like from the chart you had, Midwesterns have more alcohol consumption than other states? Is there any reason to that?
You know, I'm actually still learning about that. So I can't answer your question directly, but it's certainly something I've been curious about. Things that I wonder about are climate. I come from Canada, and one of the things that I've noticed is that the colder the climates, the more the alcohol consumption. But there's also those structural determinants that go along with geographical sort of environments as well. So I think it's certainly very multivariate. So, but I would be happy to, take your contact information and then send off some things after a bit of research to you, if you like.
Okay, yeah. And I also, do you guys have like any handouts as far as increasing awareness of alcohol consumption connected to cancer that we can hand out to patients?
I don't know if Kathleen, you or Sylvia have any specific handouts, but I can speak for the Minnesota Cancer Alliance. We don't, but that's a good idea for us to create.
It's certainly an action item that we should focus on as soon as we're done here. It's a very good question and certainly something that we can work on.
Yeah, those are great questions. Thanks, Shar. Michelle also put in the chat a question. Will dietary guidelines recommending moderate alcohol use for those who choose to drink or chose to drink change based on the relationship between alcohol and cancer? I don't know if either of you can answer that.
I think that there is been an effort in trying to revise the guidelines, and there has been certainly a lot of discussion around it. I think that the Surgeon General report was actually focusing on providing guidelines on the alcoholic beverages, was suggesting and proposing to have more clear information on the labels of products. And so I think that there is a general consensus that we need to do a better job in providing guidelines that are more refined. Again, the problem is that granularity that we would like to have in order to be more precise in providing information, I think is still debated, and therefore we haven't landed on any practical action yet. But I don't know if, Kathleen, you have anything else to add on this, but this is just from the general perspective, the positions also that I've sort of heard from IARC and other international references.
I personally haven't heard anything. I think I would just echo what you said.
I certainly do know that the scientific community has been calling for an addition of information, especially around people that we know are at higher risk. And I already mentioned in my presentation that people that are carrying that genetic background that leads to a less efficient detoxification of ethanol and acetaldehyde should be knowing about it and should be considering guidelines that are a little bit different for sure. And we yet have to address that effectively.
Okay, one last call for questions.
Sorry, I have one more question, Shar, again. Do you think, I don't know if you guys were able to look back at years before. I know you mentioned earlier that the youth had, decreased alcohol consumption now. Were you able to compare that to past to see if later in life adults drank less alcohol if they started, if they didn't start as young?
Yeah, that's why the AAP declares it a pediatric issue, is because the evidence demonstrates that early initiation is linked with consumption and problematic consumption, particularly alcohol use disorder in later life.
Thank you.
But if you would like, I could try to find Minnesota specific data for you if that would suit needs of yours. I'm not sure if there's longitudinal data, but I could try to find it.
Okay, no worries. I was just thinking
Okay.
about all the things that were said today, but thank you guys for a great presentation. Enjoyed them both.
Yeah, thank you. And great question, Char. So one last thank you to today's presenters, Silvia and Kathleen. I think the recording and the slides should be on the Minnesota Cancer Alliance website in the next week or so if you want to check those out. But otherwise, thank you everyone for spending your afternoons with us.
Thank you, everyone.
Bye.
Thank you.